guys, welcome to another episode of Tech Tuesday. I am so glad you're here. I have got Patrick Tarnowski. I should have gotten a pronunciation. How badly did I butcher it?
You nailed it. You got it right.
Right. With me, we're going to be talking about the other vital sign that nobody's talking about, right? But before we get into that conversation, this.
Hey guys, Steve Moran here.
So Patrick, welcome. I'm sort of laughing in my head. You and I spent the last 3 days together and didn't even know it until 5 minutes ago. We were both at the Senior Living 100 conference, and it's a fairly small conference. It's like 500 people, probably. No, I don't think it's that much. Maybe 300 or 350 people. And I know even on the last day, I ran into people who were there the whole time, the morning of, that I didn't talk about. Now, I will say one other thing, though, before we get started is you've probably seen that video where the gorilla walks through a bunch of basketball players and about half the people don't even see it because they're focused on the thing that's going on. And I actually walked through about 3 or 4 different times at Senior Living 100. I've got a Insta360 camera doing some video, and I kind of walked in front of the whole crowd. And I realized that that's probably the same impact that, I'm just some video guy walking through that gets ignored, even though I'm walking right in front of people. No offense to you. I think I would do the same thing, but it just is really funny.
I'm taken.
So,
great to see you, Stephen. Yeah, we can talk about the conference. It was boy, there were so many great learnings and so much content. We'd be excited to get some of your take on it as well, given we were in the same city, in the same hotel for 3 days and we didn't see each other.
Yeah, it was lots of great conversation. We'll have lots of great content coming out of it. Lots of new guests for both our Tech Tuesday and Foresight TV. But Patrick, let's start with this. Tell me about who you are, who OneStep is, the problem that you are solving, your passion for making the world for older people better.
Wow. Yeah. Again, pleasure to be with you and your audience today, Steve. My quick story. I've been so fortunate to really touch all parts of this crazy healthcare ecosystem over the past 40 years. So I started my career as a physical therapist. Most of my practice was on foot and ankle and lower extremity biomechanics. So, kind of from the jump, or maybe I should say from the first step, I had really just this passion and this deep, both clinical and professional curiosity around how people move, and treated for many years, and then said, well, how might devices help this? So I was able to spend several years in the medical device world and understand that lens. And so we know how providers look at this. Now, how might devices look at this? And then took a shift after many years in the device side. Again, I touched all parts of that world into larger health systems. So I was fortunate enough to lead the entire rehab service line for a very, very large health system here in Minnesota. And so it was everything tied to medical rehabilitation, from acute to chronic, from pediatrics to geriatrics to sports and orthopedics and cardiology and neurology and mother baby, and all elements of this idea of how mobility and how rehabilitation are a very, very horizontal function. We sometimes bucket in healthcare seniors, pediatrics, oncology, orthopedics, but there's commonality across all of them. Whether it's what are your vital signs, what are your there's some common threads. One of them, though, has always been about mobility, and it's been challenging to measure and monitor that mobility. And, after the health system, I was able to spend time on the plan side. So worked inside of the payer environment and learned so much. Wear lots of leadership hats there, and learned that the payers, while sometimes the providers and the payers do this, the payers and the providers are actually philosophically more aligned than I think we think about. We all want better care for all patients or members. We all want lower cost, and we all want very engaged providers and patients or members. It's just that in that last one, there are different levers that they can pull.
Yeah.
So with all of that, I think my career, my focus has really been about this idea of mobility and how important it is to health. So, jumping into just briefly on OneStep, this is the problem that we've solved for. We don't have to prove anymore that gait and mobility are important indicators of health. There is this deep body of scientific literature about the way that you move correlating to falls and correlating to cardiology or cardiac function, metabolic function, mortality, morbidity, hospitalizations, dementia. But we've been limited to, me eyeballing you, Steve, in the practice this way, or these, $500,000 gait labs that are just not practical, and they're not expensive, or they're so expensive they can't really be used in a day-to-day setting.
So I want to stop you for just 1 second.
Yeah.
I think I know what gait is, but I'm
Thank
not
you.
sure I do. And maybe there might be some other people who are watching who also don't really know. They sort of know it's about walking and stability. And so let's actually back up and talk about what gait is.
Yeah, such an important thing. We and I think what you just described, that question you just asked, is it's such an important question, because as a provider, I may start saying, Steve, your gait this and your velocity that and all of these things. And as a patient or a resident, you might say, what the bleep are you talking about? Exactly. So let's just restate, gait really is, and it's GAIT, not GATE, like your picket fence gait. But gait, it's how we walk. It's how we move. It's how we get from here to there. And it is a very complex function. We tend to think it just mostly works, but there are so many components to it. There's neurologic component, there's orthopedic component, there's biomechanical, there's muscle component, there's how much energy do we have, or breathing. All of these things contribute to how we move. And when we talk about, I referenced this body of scientific literature. I mean, there are truly thousands of studies that are published. So about how important gait is, first understanding it, and then how important it is. And I'll just reference one statistic that seems to always, or what figure that always seems to create clarity. We know, so let's focus a bit on the senior side. And we talk about how gait speed. In other words, how fast are we walking? There's a bit of this magic number that if your speed is, and I'll geek out here just for a moment, but if you walk at 0.8 meters per second, you tend to have that would be generally age and gender adjusted. You're in the okay zone. If that speed drops even 0.1 meter, if you drop to 0.7 meters per second, your fall risk goes up about 8%.
Okay, so how much is that? What speed is that in miles per hour in real life, so I can understand that?
Yeah, you're going from 2 and some change to down to about 2 miles per hour. Okay. So, or even a bit slower. I should have my metric conversions. That's off the top of my head. So okay, it's pretty slow. You and I walking around at Senior Living 100, Steve. We're probably at we're right around 3 to 3.5 miles per hour.
Yeah,
and okay, that's our sort of average walking pace. So if that speed drops just that little bit, your risk of dying goes up about 12%. Your risk of going to the hospital goes up. Your risk of heart disease or cardiometabolic disease goes up. So hopefully that's just kind of a nice reference point around just this idea of what gait is, and give a little context about how even subtle changes can be really important.
Okay, so what I'm hearing you're saying is that if you can measure somebody's gait, their speed, and how they walk and move, you can predict things like falls and perhaps other things. Is that Fair
Yeah,
statement.
yeah. It's a really important leading indicator of health.
Okay.
And,
So you would offer that we should be looking at that like we look at blood pressure and temperature and O2 and some of those those things that
exactly.
they check every time they go to the doctor's office.
Yep, you're spot on. And I think reference a little bit of senior living. We heard a lot of presentations about how the owner operators, the forward-thinking organizations are moving much more into the prediction. How do we take all these disparate data sources and start to swim upstream to identify the problem before the problem occurs?
Yep. So how do we do that? This is my setup question for you.
Yeah, how's that? So traditionally, I may, if you're in my clinic, Steve, I may, measure off a certain distance, put a piece of tape here, put a piece of tape there, say, okay, ready, set, go, start a stopwatch, and then do calculations to say, took you that long, and that translates into a certain speed. Not practical, and certainly it doesn't, Steve, tell me how you're moving when you're outside of the four walls of the clinic. So that's what we'd solve for at OneStep, where we turn smartphones into clinical grade gait and mobility labs. And then we bring that data back to our senior living communities, their residents, to the providers, to help them understand how their residents are moving in both their clinical setting as well as in their natural environment. And it's really interesting, Steve, because we're able to see as early as 2 weeks in advance a decline in mobility 2 weeks in advance of the fall occurring. So just by having a phone in a pocket or a pouch and walking 10 steps and doing it passively, anytime that they have their phone with them, we'll be on and capturing data. We bring this important signal back, and we're now in, Steve, about 500 plus senior living communities. And where we're deployed, our partners are reporting back to us that they have seen their falls come down between 23 and 25%. And that's not just a Hawthorne effect. That's been maintained over several years. So there's, are we the only reason that falls have come down? No, you can never say it's a one-to-one, but we're the variable that changed, and we're giving them insights that they've never had before. And I think that's part of the reason we're just having really good success, because it's a great story to tell, because we're helping providers, we're helping communities, we're helping patients. And that's, if we can do that, we can feel pretty good about the mission that we're on.
Okay. I've got 3 or 4 really sort of quick questions that I wanted to unpack this. Mm-hmm. So can go on any cell phone?
Yeah, any smartphone.
Okay. And does it monitor continuously, or is it doing just as a test? I've got my stepfather in a senior living community. I'm not sure his current smartphone, he's got one that's very dementia specific, would work for it. Probably not. So could I put it on my phone and then stick it in his pocket for 5 minutes, and would that work?
Yeah. So the use case is pretty simple. So we'll be generic here for a moment. Let's say you're in my clinic setting, or I'm come to you in your room in a senior living community, maybe on the skilled side, and let's assume that you don't have your own smartphone. I've got a inexpensive rover phone or facility phone that may actually be the phone that I'm using to do my point of service or point of care documentation. Yep. And then it's been really fun, Steve, to see how creative our partners have become, where they'll say we do measurement Mondays or testing Tuesdays. And just as we would round every day on our residents, every Monday, I'm going to take a phone, drop it in a little pocket or a little pouch, and have you walk 10 steps. Done. I've completed the full analysis. And then I could do some other really important things with the OneStep app, like a sit to stand and a timed up and go. And I can assess balance and sway, and I can add cognitive load to see if there's a connection between how you're thinking and how you're moving. And then that data is really helpful for the nurse care team or the care team to be able to say, oh, you really should be in a therapy program, or let's make sure you're using your assistive device, or, since you've been on this medication, we've noticed a change in your function. or it's more likely that if you're going to fall, it would be to the left. So let's set up the environment that way. So that's my, on the skilled side. As we move over to the independent and assisted living side, our data and our partners we're seeing that it's closer to 60 to 70% of those residents have their own phone. So think of every new move-in gets assessed. There will be some questions that typically happen at move-in.
Right.
Now let's get just a baseline on how you're moving. Take a short walk, do a few things, and we could say, Steve, here's your data, and you'd say, that's great. I may say, whoa, upon move-in, you've got some risk of fall. Why don't you make sure we get you into our wellness program? And the wellness team is using OneStep to be able to measure, monitor. And we could also say, Steve, we can, part of the way we like to wrap our loving arms around you is to have you put this on your own phone. And then anytime you're moving about, we will get data passively. So your question about, is it an active assessment or is it sort of an always on passive monitoring? It's both. And that gives us the best of both worlds, because the way you move in your own environment is usually pretty different than how you move when you're being observed. So we get both of those, and then we make that available to you, to your family, and to the community.
So what if somebody's using a walker already? Does it still work?
Absolutely. Yeah. Okay. And again, very, very interesting, very interesting data where we have many partners that are using OneStep to help them determine what is the right level of assistive device. So let's walk, I'll make it up. Let's walk without. So we get some baseline. Let's try a cane and we see what that looks like. Let's try a walker or a rollator and we see, wow, that's better. Or what if we have one that's a little bit taller? Oh man, now you're off to the races. You're much more symmetrical. Things look really good. So it's actually a really nice tool to sort of close the gap between what's otherwise been kind of observed, inconsistent, or subjective with really good objective data. And we do it really, really simply and easily. We get rid of the need for the expensive and sometimes difficult to maintain and use hardware.
So let's talk a little bit about cost.
Yeah.
What's it cost?
It's pretty simple. So we license the software into our partners' facilities, and we've learned from our partners, rather than licensing it on a per room or a per resident, which we learned is sort of a disincentive. There are times that folks say, I don't think I should. So we just bring out with a straight license, and we price on a per community or per building per month basis. Starts at $800 for unlimited numbers of providers, unlimited numbers of residents. And then as our partners add more buildings to it, it starts to scale down. So, once we get into 10, 20 locations, it gets very, 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 even more affordable.
Okay, terrific. And is it reimbursable?
Yeah. Such a good question and really exciting. So at the risk of another long answer, we'll talk about some of the economic value that we bring across the continuum, because we like to take the framework of, we need to deliver products that are under the CEO model. It has to be clinical value and validation. So we talked about clinical value, and we've published 15 peer-reviewed papers that shows what we do is valid across the board. There has to be economic value, and there has to be operating value. In a past life, when I was at the health system, we used to say all good ideas go to the bedside to die, right? Yep. Because if the team can't implement them or they choose not to, even if it's the best thing, it's just not going to work. So from a economic value, let's go back to the skilled side for a moment. The value that those providers are seeing using OneStep. One, are they billing for the service in the clinic? No. On a Medicare Part A, that doesn't happen. However, they receive value in that fall risk comes down, quality scores are better, fewer people going to the hospital, all of those good metrics. The second thing on the skilled side that's been very powerful is our partners are taking data and bringing it to their managed care partners and saying, look, I know you want to kick Mrs. Jones out of the nursing home. Don't, because she's still at a very high fall risk. Here's the objective data that says she's not ready. So give us 5 more days, 7 more days, and we will show you that she's at least stabilized, or ideally she's getting better.
Right.
And managed care is listening to that. So on average, our partners are seeing 5 to 7 additional days on the skilled side. So not only is that good economic value, but it's just the right thing to do. As you move over to the assisted living and the independent living, actually I'm going to add one more part of economic value on the skilled side. We now have the liability carriers coming to us and saying, hey, where you're deployed, falls have come down. The two top reasons for a liability claim in skilled nursing are falls and wounds or pressure sores. So if the falls come down, now these liability carriers are able to go to their underwriters and ask for a lower quote. So that's real value back to the owner operators. So then move over onto the assisted independent living. If you're in my clinic, as I say, I'm your therapist. I'm using OneStep as an assessment tool. I can bill for that service. I can bill for those assessments. And if you go home with OneStep on your own phone, I can then bill for remote therapeutic monitoring. Much like remote patient monitoring, the Bluetooth
Right.
blood pressure cuffs and all of those.
Yep.
Remote therapeutic monitoring now allows PTOT and speech to bill for these remote services. And then thirdly, the economic value on the AL and the IL side, if we're identifying the fall risk and reducing the number of falls, from an owner operator perspective, the occupancy rates improve. And we heard a lot about that at senior living.
Yeah.
How do we sort of close the back door? How do we help keep these residents in their facility of choice longer? And we know that as soon as a fall occurs, the likelihood of them staying or coming back to that previous level of occupancy starts to go down. So again, there's economic value kind of across the whole post-acute continuum.
So I want to talk a little bit about what happens when. And what I mean by that is I've got a resident who's carrying this device. The device comes back and says, hey, this person has got a increased fall risk because of, and so then what do I do? I mean, how do so I know that there's a risk. What do I do about that to mitigate that?
Yeah. So you as the resident will get some notice that says, hey, Steve, we've noticed a change. We won't necessarily say to the resident, oh my goodness, your fall risk has gone up. But we will say, hey, compared to 2 weeks ago, something has changed. Are you okay? You may want to talk with your team, et cetera. From the care team's perspective, we will see Steve's risk of falling has gone up because of A, B, C, and D. Now let's take action. Think of it as if your blood pressure were going up.
Yep.
Your care team would see the vital sign change in their EMR, click into it and say, okay, now let's understand why. Steve, let's talk. Is it a medication? Is it a food? Is it a fluid retention? Whatever it may be. Same sort of thing here. We've seen your fall risk go up. Let's understand why. Well, these few gait parameters have changed. Your patient reported outcome, your fear of falling has gone up. The time it took you to do a standardized measure like a sit to stand, the things that are routinely done in senior living or timed up and go has changed. Now we've got the objective data to know how to more effectively target our intervention.
Right. Okay. So when does it work all the way through until somebody becomes bedfast? And so we do the interventions and we don't need it anymore, or do we continue to monitor even after the changes have occurred?
Yeah. So let's assume for a moment we're talking about a resident who remains ambulatory.
Yep.
We could have sort of a snarky reply that says, well, how often do we want to measure somebody's blood pressure? That's a
good point. That's a good point.
Intentionally snarky on there.
A lot.
Right. So if somebody is not mobile, then the gait assessment tool probably isn't that important at that point.
Okay.
Yeah.
So one of the things that kind of pops through my head, and particularly coming off of Senior Living 100, where a lot of discussion about technology tools to be used from the platform, a lot of vendors with technology solutions of all
It's a very crowded front door, as we've heard from many people.
And I think back to when I first started doing content on senior living, when point click care was around, a few other companies, a little bit of technology, but there was still a lot of paper and pencil. I remember a time when less than half the communities even had pervasive Wi-Fi in them, right? So it wasn't been that long ago. But now I'm looking at it and I'm thinking, how does somebody manage all this technology? And how do you avoid the fatigue? What does it look like in terms of notifications I get so I don't get into this notification fatigue? Talk to me about that.
Yeah. And it's such an important point. There's app fatigue, there's point solution fatigue, there's one more disconnected something that somebody needs to pay attention to. And we know there's just this tremendous workforce crisis in senior living. It's so hard. And so, we hear over and over, hey, I like this, but if this isn't easy for my team to use, or it doesn't integrate into their EMR, it's just not going to happen, because I can't ask my team to do one more something. In fact, in a past life, when I was leading a large health system and we would get here's a new regulatory thing, here's a new click that our team needs to do. We started literally the one more thing file. And, about 6 months through the year, we brought it back to leadership and said, you've one more thing that's like 68 times. And we just can't keep doing this. So how about if we have the one less thing, right? So back to your point though, we recognize that, and we've built the platform to be able to integrate. So we've gone very deep into all of the big EMRs in the senior living space. Mm-hmm. And in fact, it's been very sort of humbling and positive to have those EMRs now coming to us and saying, your footprint is good. We're hearing from our customers that we want your data. You're this functional mobility intelligence layer that we've been missing for years and years. So we live inside of the EMRs with the idea that it's one less place for the providers to start doing work, or to go searching for data. Because we're not another hardware, it's become much easier to implement and use. It's just a software, and it's something that speaks the language of this patient population and the provider space. So those things have been, by design, because we've started with the idea that if providers don't find value and can't use it, then we don't have a business model. Because there's been great tools over the years that have, hardware that have measured mobility and gait. But again, they're just expensive. They're hard to maintain. And sadly, and I've had lots of clinics under my purview, there's a lot of clothes racks, sitting in clinics that just don't get used.
Yeah, it's a very hard question for me, because I think, and that I look at solutions like yours and so many others where I go, oh man, that is so cool. That can really change the lives of residents, of family members, of operations. And then I step back and put my senior living consumer hat on, and my stepfather has increasing sundowners. And and he's on hospice. And a hospice nurse reached out to me while I was in San Diego at Senior Living 100, and the hospice nurse has got this patient load, and he's just trying to move through his load of patients, and his answer to everything is another drug. And so he comes back and he says, more sundowning, we're going to increase this particular drug, and I because it's an easy answer, and I'm going, no, I don't think we're going to do that. And so I think that the question I have for you, and this is it's not almost your fault, but you end up sort of having to deal with it, right? is I get my OneStep tool says, oh, so Gary's has an increased fall risk. Oh, well, let's just figure out how to tell him. We'll just tell him he has to sit in a wheelchair all the time, and then that will go away. How do we avoid that? And this is more of a philosophical question, honestly.
Well, actually, I can give you a few evidence-based responses to that philosophical question.
Great.
So one, in no particular order. One, at Senior Living 100, we heard several presentations about organizations that are looking at a true 360 point of view of their patients, almost like the FICO score, as one CFO from an organization I was sitting next to said. So they're going deep into their EMR and looking at all of this data, pharma, nutrition, comorbidities, and using that to help inform a better care path. So the organizers or the operators, the IT and clinical teams are already thinking very comprehensively. And for the first time ever, now that we've got smart AI tools, this is a great application for AI. We can scrape that data and start to get a good picture. What is changing about your point about, well, let's just say you're no longer on ambulator, we're going to put you in a wheelchair. What's changing is and this is a OneStep perspective, but very real. The conversation has changed from, yeah, I know mobility is important, to, oh, you actually have data that will be meaningful to us. I want this in. And so even I would say in the last 18 to 24 months, Steve, the OneStep conversation with senior living leaders has moved from, tell what now, to you would be very complimentary to what we're trying to build. Yep. And third point on this, we were recently accepted into the ARP HTech Collab, which has been so interesting. It's a great ecosystem for the plug for those of you who are considering even a mature company like OneStep. It's been a very, very valuable experience. Where you are given access to curated interviews with leaders from across industry, as well as consumer surveys. So we've done, don't quote me on the numbers on this, but surveys with many, many hundreds of seniors that are, that we're asking them things, or the ERP is helping us to ask questions about how important is mobility to you? How important are falls? How important is gait? And, those sorts of things. Right. And the overwhelming response is, this is super important to me as the consumer. Yeah. So I think a lot of things are pointing in the direction of adding this mobility intelligence layer into models starts to become really important. And especially in the advent of, we won't have time to go deep into the conversations about value-based care that we had at Senior Living, but if it's becoming more and more important and required for the senior living owners and operators to demonstrate the impact of their interventions and their care model. And function is a key driver of success in any way that we measure it, but especially in the fast-growing value-based care models that are coming into the same arena.
I think it's so important. I mean, the other thing I think, and I think this is huge, is that we get almost overwhelmed with the interventions that we can do, and so figuring out the ones that we should do becomes part of that challenge. And it feels like you've really simplified that. So I really appreciate that. We're a little over time. So sort of one more quick time. Where do people find you? They're interested. They're saying, I think this can help my community. It can help my residents. What would somebody's next step be?
Yeah, so a couple of things. They can certainly go to our website, onestep.co. No, I'm on the end, just onestep.co. There's a wealth of data on there, our clinical validation, white papers, case studies, and then click here to learn more. Feel free to reach out to me directly. It's pat@onestep.co or through LinkedIn. Happy to connect with anybody there. We would love to have this conversation to better understand what are you trying to solve for? Here's how we've done it. Maybe we're a fit together. At a minimum, we just love having the conversations and even getting into the pipeline of this idea of gait mobility are really important for your organization. When the time is right, let's go figure it out together.
Perfect. Thank you very much, Jada. Thank you for producing in the background. Thank you for watching. We really appreciate it if you got something out of this and you shared it with your network on LinkedIn and other channels. we'll be back on Friday with another great leadership show.